we shall get a lot of information today and a lot of teaching points from Dr. Amna إن شاء الله. تفضلي دكتور أمنة.
مرحبا. Good morning everyone. Thank you Dr. Muhammad for the nice introduction. The voice is fine. You can hear me?
تمام دكتورة. تفضلي.
Thank you. So last session we spoke about the chronic lung disease and the definitions, pathogenesis, the risk factor, and today we'll go to the part 2, which is the management. So I will move my slide to the management. Can we make it big? How we can make it big? Okay, how we can make it big here? This one? This one? So, yeah. We believe that to prevent the disease is much better than you end with the managing it. So دائما احنا نقول الوقاية خير من العلاج. So first we'll talk about how to prevent the bronchopulmonary dysplasia. And first you have to target your population. So usually the neonate less than 30 weeks and less than 1.25, they are the target population, and they are the one who can end with chronic lung disease. Also, the other population, the patients with the history of chorioamnitis and the history of did not receive any antenatal steroid. So the goal of our management in any case of bronchopulmonary dysplasia first is to promotion of growth to enhance lung development and repair. So good nutrition, and this is what really we are believing on it, that if you give good nutrition, you will help to repair tissue repair and lung development. Then try to minimize further lung damage by avoiding as much as you can invasive ventilations, and try early CPAP. Then optimize of lung function by good lung recruitment, and then detect and manage of acute pulmonary decompensations such as pulmonary hypertensions, and prevent infection and support the neurodevelopment. Okay, just 1 minute. Dr. Muhammad, how can I make this one bigger? Can you see it bigger screen? Dr. Muhammad?
We can see it bigger, Doctora, yeah.
You can see it as big screen or small slide?
No, full screen, Doctora. Yeah.
Full screen. Yeah, because with me is only small slide. Okay, thank you. It's okay. Yeah, this is the way that it can be. But can it? ما أقدر أشوف السلايد. Sorry for that, because I cannot see the slide, the problem with me. But for you, it's fine, yes? Dr. Mohammed?
Yeah, we can see it, Doctora. Yeah, the last slide now showing the last one you were speaking about.
Yeah. Because, you know, for me, I cannot see it very well. So we'll go through the bronchopulmonary prevention measurement. And first, we'll start with, I think this is antenatal steroid. I cannot see it. So we know that the antenatal steroid is a major advance in prenatal care, and mainly it can help. They give it to the gestational age between 23 to 37, and it will enhance lung maturations. This one. It will help to reduce the severity of RDS, improve the mortality, and there is also evidence that it will improve the severity or the outcome of bronchopulmonary dysplasia. The second one, you can read the second one. I cannot see it. It's surfactant. Hello, Dr. Mohammed.
لا احنا لسه عند السلايد بتاع اللي هو البريفنتيف استراتيجي دكتوره.
So bronchopulmonary prevention strategy, yes?
تمام تسلم دكتوره. Other slide does not came.
خلاني أشوف my presentation from here. Okay, but how they cannot see it. Design. والله احنا محتاجين yeah. Hello? You can yeah, that's now much better. Thank you. Surfactant you can see the schedule of antenatal glucose surfactant and Lisa technique. Can you see it? Hello, Dr. Mohammed. Can you see it?
طيب ثواني دكتور.
Slide number 23.
Slide 25, دكتورة.
You cannot see slide 23.
We can go back, Doctora. Yeah, the same. Okay.
Yeah, I changed to slide 23.
23, huh?
We are still waiting for Dr. Amna.
تمام يعني
Yes, yes, Doctor. The problem with us is the slide is not. يعني it's maybe clear with you, but is not clear with us. We cannot see it.
We can take control from here, Dr. Amna. If
Yeah.
you don't mind, can just طب okay. Last slide. I am going now with the slide. Let me check.
But can you put 23 slides? Can
Okay.
you do like this?
Now we have 23, Dr. Amna. So
Yeah.
I will take control. So just tell me next, and I will
Yeah.
do the next.
So I will go. I will go to my presentation, and then you can see the slide. Yes.
Yes, we can see the slide now. We kept at 23, side 23 of 241. Okay,
Yes.
show presentation, Dr. Amna. Okay.
Yes, thank you. So the treatment strategy are to reduce the exposure to invasive ventilation and to minimize long-term lung injury. Just what message I want to give to an audience that lung injury is associated with a brain injury. So you can find a baby with normal ultrasound, no IVH, and no evidence of ischemia or echogenicity, but he can end with poor neurodevelopment outcome because of bronchopulmonary dysplasia. So to reduce the lung injury or to reduce the brain injury, we have to reduce the lung injury. So what we want to give that if the patient, you can manage him on CPAP or on non-invasive ventilation is much better than you invasive intubating him. Intubate if it's only indicate. This means intubate if the patient's really showing ongoing RDS, showing a high FI2 requirement or poor ventilation. So now the advice is to use minimum invasive surfactant administration, either LISA or MS technique, and the aim that if this patient end with intubation, better to use the volume guarantee, or they call it protective ventilation. So usually we put them on assist control, volume guarantee, or you can put him later on SIMV with the PS with volume guarantee. But the aim is to put him on low tidal volume between 4 to 6 ml per kg, early wean from mechanical ventilation and early CPAP. So usually what we said, baby more than 24 weeks, extubate as soon as the baby show us the redness that he's ready to be extubated. Don't prolong his intubation. Patient less than 24 weeks, like 23 or 22, you may ventilate them for 72 hours and then extubate as soon as the patient is ready. So, and then target your oxygen saturations. That's mean target the saturation, and we know that everybody know about support trial, and please the fellow read about support trial that they suggest to keep saturation between 90 to 94, and some studies say 91 to 95. And also when you target your oxygen saturation, please don't forget to target the alarm. Your alarm set is essential in each extreme low birth baby. Then we'll move with the early therapy of caffeine, and I'm talking only now about the drugs that it may help to prevent, or it may help to reduce the severity.
Can I interrupt you? I just came to know that we all cannot see your slide.
You cannot see my slide?
No, I thought it's only me, but I can see in the chat now. Obviously, all of us cannot see your slide.
Just to show the slide, Dr. Amna, and I am here with Asma. She can control it from here. So last one, we have reached 23. Can just show the 24. So Sister Miss Asma can take over, and she can proceed with the slides once you speak. Share the slide, Dr. Amna. Share the slide. Share the slide.
بقول لك الحقيقة المرة إني أنا ما كتير شاطرة بالأشياء هذه. Okay. العقاد وين أنا رايحة؟ كنسل. اوكي يلا.
وين التيمز؟
هذا التيمز. يا لهوي
طلعتي من قبل.
يا لهوي. اوكي. I can hear them عقاد. I can hear them. أيوة اوكي. يلا. شنو هاي تكنيكال.
تسميه
تسلمي. هذا عقاد ما لي شغل. هذا
بس قاعد بسكر وانت ايش فتحتيه هذا؟
اشتغل. شو فتحت؟ اوكي. We are here. اوكي. كانسل يا عمي كانسل اشيله كامل. يلا خلك انت من هذا. شيرين. اوكي. شو نسوي عقاد؟ افتح البروجرام شيله ديليتد عقاد.
هذا برودكاست دكتورة كيف بتسميه؟
اشتغلي. يلا finish it sharing. يخرب بيتك يخرب بيت البروجرام. sorry.
Okay, Dr. Amna, we can see the slides now.
طيب دكتور أمنة, as Dr. Yasser said, we can see the slide now. So let us take control from here. So we shall go to slide 23. Okay, so let us see. Now we are going with the slides.
Sorry for that. Sorry.
So okay,
with technical things.
Hello.
Yeah, can you stop here and can you make yes? I'm talking about this schedule, which is PPD prevention methods. Asma, can you go back to 23, please?
Okay.
Hello, Dr. Mohammed.
Hello, she's doing the 23.
Yeah.
Yeah, 23. Okay, تمام دكتورة, تفضلي.
Okay. Then we spoke, and now we spoke about the target oxygen. Then we'll go with the early therapy with caffeine. The caffeine is indicated in the first day of life for any preterm baby less than 30 weeks and any preterm baby his weight less than 1.25. Maybe different protocol, different units, but this is what we are practicing in most of our practice. So we know that caffeine from the CAP trial. You can see? You can see? Yes, so we know from the CAP trial that caffeine reduced the risk of bronchopulmonary dysplasia. Caffeine can shorten the duration of ventilations and also improve in the cognitive and motor outcome at 18 months. And this is the conclusion of CAP trial. Then we'll talk about vitamin A. Vitamin A, it showed to reduce the, they have rule in lung maturation and repair, and it showed reduce the development of bronchopulmonary dysplasia. But vitamin A, you know, it's intramuscular injection, and not all the centers practicing that. Then I will have different slides. Yes, try to control the postnatal infections. to reduce the inflammation mediators and to reduce the and the need of mechanical ventilations. Then hemodynamic